Today's medical-centric topic is endometrial hyperplasia, progression to cancer, and prevention. Why endometrial hyperplasia deserves attention. Endometrial hyperplasia is a common yet often underestimated gynecological condition. While many cases are benign, certain types carry a significant risk of progression to endometrial cancer. Early recognition is critical because timely treatment can completely prevent malignant transformation. What endometrial hyperplasia actually is. Endometrial hyperplasia occurs when the lining of the uterus becomes abnormally thick due to prolonged estrogen exposure without adequate progesterone. This hormonal imbalance leads to excessive proliferation of endometrial glands, disrupting normal tissue architecture. Who is most at risk? Risk factors include obesity, polycystic ovarian syndrome, chronic anovulation, perimenopause, estrogen-only hormone therapy, early menarche, late menopause, diabetes, and tamoxifen use. These conditions share a common feature: prolonged, unopposed estrogen stimulation. Types of endometrial hyperplasia matter. Endometrial hyperplasia is broadly classified into without atypia and with atypia. Hyperplasia without atypia has a relatively low cancer risk and often responds well to medical therapy. Atypical hyperplasia, also called endometrial intraepithelial neoplasia, carries a much higher risk of progression to endometrial cancer and may already coexist with early cancer diagnosis. Symptoms that should raise suspicion. Abnormal uterine bleeding is the most common presentation. This includes heavy periods, irregular cycles, bleeding between periods, or postmenopausal bleeding. Any abnormal bleeding pattern warrants evaluation, especially in high-risk women. Risk of progression to cancer. Hyperplasia without atypia has a low annual risk of progression when treated appropriately. In contrast, atypical hyperplasia has a significant likelihood of progression to cancer if left untreated. This is why accurate classification through endometrial biopsy is essential. Diagnostic pathway. Transvaginal ultrasound may show a thickened endometrium, but diagnosis requires endometrial sampling. Biopsies confirm the type of hyperplasia and guides management decisions. Prevention starts with hormonal balance. The cornerstone of prevention is reducing unopposed estrogen exposure. Progesterone therapy, oral, injectable, or via levonorgestrel intrauterine device, is highly effective in reversing non-atypical hyperplasia and preventing progression. Role of lifestyle interventions. Weight reduction, improving insulin resistance, and managing metabolic health significantly reduce estrogen excess from adipose tissue. These changes not only treat hyperplasia, but also lower overall cancer risk. When surgery is considered. For women with atypical hyperplasia who have completed childbearing, hysterectomy is often recommended due to the high risk of cancer. Fertility-sparing options may be considered in carefully selected cases with close monitoring. Why surveillance is essential. Even after successful treatment, regular follow-up with repeat biopsies is crucial to ensure regression and detect recurrence early.
Thank you for watching our video. Please do not forget to like and share the video. Also, please subscribe to the channel to stay updated on our latest videos.